Good afternoon, everybody. Welcome. We meet as the Strategic Commissioning Committee for Lancashire and South Cumbria Healthcare Partnership. We meet informally today. We're joined today by a number of members of the public who've registered to join in our meeting. You're very well. We appreciate your interest and welcome your involvement in our meeting today. Can I remind you, please, if you're here to observe, to keep your camera and microphone switched off. It just helps my management of the meeting and the people I can see on the screen, and also to respect that the text column that we have is also just for members of the committee and forms part of the record of our meeting today. I have a number of apologies that have been received. Dennis Gitzi, Kevin McGee and Gemma Stanion's here for Kevin, Adam Jandra, Kevin Tools here in his stead, Linda Riley and Claire Thomason's here, from Jane Scattergood, from Graham Burgess and Julie Higgins, but both Roger Parr and Richard Robinson are here to cover the business from there. Jane Cass will be joining us a little bit later. So, welcome. At the core of our meeting today is the consideration of the shortlisted options for the new hospitals programme, a very important business for us to do together. Likewise, the update on the CCG close down and the transition to the ICB. It's very important on those two items that we have full consideration and that all members of the committee have the opportunity to ask questions and to express their views. I'm conscious that the paper on the delegation of NHS England's commissioning functions only come out today. I apologise for this. We don't expect and we can't reasonably expect a detailed consideration of a paper that circulated for good reason, but circulated so late. But Peter will take us through the headlines of this and what we need to understand now, pending further discussion later. Brent joins us on the medicines management and policy issues, and we'll receive the performance update, quality and performance update from Roger and Catherine. I've received no new declarations of interest. If you feel in making a contribution to the meeting that there's an interest that that hasn't been raised before and that others on the committee might not be aware of, please acknowledge that in your contribution. We've got the minutes of the formal meeting on the 13th of January here. Feels a long time ago. Can I propose that we accept the minutes of the meeting? Kevin, sorry, do you want to come in on the minutes?
Yeah, just briefly, Chair, thank you. It's just to declare that on item 6, the new hospital programme, I've been working with the Comms and Engagement Oversight Group on that programme, so it's just to let colleagues know of that fact.
Thank you. Samantha.
Thank you, Chair. Just to update that, I don't know whether it's in the declared interest or not, but I'm in the clinical oversight group of the new hospitals programme.
Thank you, Samantha. Okay. All that goes on the record. Right. Minutes from 13th of January. I propose that we accept them, please.
Formally second.
Thank you, Roy. Thank you, Jeff. Andrew, over to you.
Thank you, Chair. Just two key messages today. The first, just a confirmation of some national correspondence around the timings of legislation, and the second, a brief mention of the operational planning process. So I think On the first of those, I think colleagues will generally be aware of correspondence received from Mark Cubban in the National NHS England team at the beginning of this month. Mark wanted to update on a letter he sent before Christmas, just to confirm again that the national expectation is that legislation is in place to be complete by the end of March, and thereby the new Integrated Care Board would commence operation from the 1st of July. So that is the planning timetable we are being asked to work with. Not surprisingly, we've had to respond by adjusting a number of our existing timelines in the weeks since our last meeting. But again, Mark's letter made it very plain that CCGs continue to operate as statutory bodies to the end of June. Collaborative groups like the SCC play an important role in the conduct of business between now and then. And CCGs are asked in the letter to work effectively with designate ICB leaders. And of course, perhaps notable to say that our Chief Executive Designate for the ICB, Kevin Lavery, begins his time with us next week from the 14th of March. And as part of his induction programme, he will be meeting a number of CCG colleagues in the coming weeks. So that's important to emphasise. And again, another important expectation in the letter that ICBs will inherit the relationship with commissioning support organisations and are expected also to maintain a stable relationship with them in the course of the next 12 months. And there's a requirement to submit a plan in response to that request by the end of April. So that will build on existing discussions that we have with our CSU colleagues who provide a wide range of support in Lancashire and South Cumbria. So that was the first message. The second message hasn't been placed on the agenda today, but simply to say CCG colleagues working intensively at the moment with ICS and our provider colleagues to complete the operational planning process for 22-23. We obviously are working with the national expectations around planning. We have to complete a number of particular templates and submissions, and that work is going to continue over the next few weeks. So perhaps we'll pay some recognition for that when we get to our next meeting, everybody. So, Chair, those were my two main messages for today. Thank you.
Thank you, Andrew. And I think that the Mark Cubban letter, which Andrew referred to, reminded us, if we needed reminding, of how important the work we do together in this committee is, and how closely the CCGs, collectively and CCGs, with the emerging ICB structure, that close working which we have formally in this committee and informally in many other ways will be vital in keeping us safe and ensuring a smooth transition between now and the implementation date. And it's the level of maturity, if I may describe it as that, in the working practices we see in our meeting together here are never taken for granted, always appreciated, and don't exist in many other parts of the country. So we've a good basis to continue to do this work together, and I thank you all for that. Jerry, Q3 report and the short list of options.
Thank you, Chair, and good afternoon, everyone. It's good to be with you this afternoon to cover what is a significant milestone in the progress around the new hospitals programme. Firstly, though, it's just to confirm that the Q3 report has been shared with you. A significant part of that report talks about the shortlisting process, so I won't go into the Q3 report in any detail, but I'm happy to answer any questions that you may have. So moving on to the shortlist, I'm going to put up a presentation now, Chair, so I hope everybody will be able to see this. Can I confirm that people can see the slides? Thank you, Chair. So the purpose of the session today is to take the Strategic Commissioning Committee through the process by which we have produced a shortlist of options for the New Hospitals programme. I will talk through the process and I will be seeking your endorsement for the shortlist of options. It's also important that members of the committee feel assured that we followed a robust and thorough process. Just with respect to the approach we've taken, we have followed both the guidance set out in the Treasury Green Book with regard to capital investment, but most importantly, to follow NHS England's guidance around planning, assuring and delivering service change for patients. This process started right back in June of last year when we launched the Case for Change. And very much since June, we have followed a process of publishing key documents and then following very extensive engagement with the public, with patients and with our staff. In the autumn, we published the long list of options, which many of you will be familiar with. That was for 10 different proposals. These range from the standard business as usual or limited investment through to a range of options, which included either partial rebuilds or refurbishment of the Royal Preston or Royal Lancaster Infirmary, through to the potential build of a single hospital on a new central site. These were published in the autumn of last year, and since then we have extensively engaged with stakeholders, gathering their views around each of these proposals. This enabled us then to undertake, at the beginning of this year, a stakeholder workshop where the long list of 10 options were appraised against what were agreed critical success factors. And I'm just going to take a moment to explain a little bit about that workshop. The workshop brought together stakeholders from across our system, including patients, members of the public, councillors, representatives from the commissioning system and from our trust providers, together with subject experts, including lead clinicians, finance people and specialists in estates. Using the information we've gathered over our engagement period with feedback from the public, together with evidence around how the options met our financial commitments, how deliverable they were in terms of the estates, and how it would benefit, most importantly, our patients and the outcomes for the population who access our services. This evidence was brought together and considered by the workshop, and they assessed each of the 10 options against those critical success factors. This was a very inclusive, very challenging and very productive session that concluded with the workshop being able to present to the Strategic Oversight Committee a short list of options. Those short list of options can be summarised as firstly, a new Royal Lancaster Infirmary built on a new site with a partial rebuild or refurbishment of the Royal Preston Hospital. Second option is a new Royal Preston Hospital on a new site with a partial rebuild refurbishment of Royal Lancaster Infirmary. The third option would be investment at both hospital sites, allowing partial rebuilding or refurbishment, with a fourth option to build 2 new hospitals to replace Royal Lancaster Infirmary and Royal Preston Hospital, built on new sites. All of those above options include investments in Furness General Hospital in Barrow and Furness. As part of the process and consistent with NHS England's guidance and with the Green Book, all of those options will be benchmarked against a no change option. There were many reasons to shortlist those options in terms of benefits to patient outcomes, to improving our clinical pathways, and to wider system benefits in terms of working with wider partners and the role of the NHS as an anchor institution to look at wider socioeconomic benefits. These were also factors that were taken into account when we considered those options that were discounted from the shortlist. The first is the new Royal Lancashire Infirmary on the existing site with a partial rebuild refurbishment of Royal Preston. Now, that definition of a new Royal Lancashire Infirmary would actually mean the total replacement of the current hospital facility with a new one. The second option that was discounted was a new Royal Preston Hospital on the existing site with partial refurbishment of Royal Lancaster. And again, to be clear, that was total replacement of the existing facility with a new hospital. For both of those cases, they were discounted because the cost of building new hospitals on the existing sites is significantly higher than the costs to build new hospitals on new sites. There is also significant patient and public impact arising from trying to rebuild on the existing sites, both in terms of the disruption of care during the rebuilding work and the requirement to phase the build over an extended period of time as patients are cared for in different parts of the buildings while they are replaced. The opportunity to look at a single new hospital on a new central site between Royal Preston Hospital and Royal Lancaster Infirmary was also discounted. The reasons this option was discounted had to take into account that the option also presented significant benefits in terms of clinical pathways and bringing together our workforce, had operational benefits, but these had to be counted against and considered against significant concerns with regards to the impact on inequalities across Lancashire and South Cumbria, the challenges to travel from our farther patches in Ribble Valley and in South Cumbria, and these had to be weighed up against the benefits. On balance, the decision was taken to discount this option. The final option that was discounted was to build a new Preston Hospital on a new site whilst retaining the existing Royal Preston site for some services, and then to partially rebuild Lancashire Infirmary. This was a particularly complex option, partly driven by looking at where our specialist radiotherapy services should be based. After much consideration, this option was discounted because it failed to meet our requirements around clinical pathways and clinical outcomes, and was also deemed to be operationally inefficient with high costs. Those were the reasons for discounting those four options. So, in terms of next steps, as I have presented in this slideshow, we have shortlisted four major options that include rebuilding rebuilding Royal Infirmary at Lancaster and the Royal Preston Hospital, and the building of two new hospitals on new sites. We will now undertake much further detailed analysis on the shortlists, including how services will be configured, which site options would be viable for new builds, and the overall financial affordability. This work will be undertaken with extensive engagement with the public, with patients, with staff and wider stakeholders. This process will enable us to reach a point where we are able to develop a pre-consultation business case, which will be subject to confirmation of the requirement to consult. The process that we've been through has been very robust, and I hope it provides assurance to the committee, and I would welcome your questions and comments. Thank you, Chair.
Thanks, Jerry. It's very important, I think, that all members of the committee have an understanding of the proposals and for you to feel able to follow the recommendation that Jerry's put in front of us to proceed to the next stage. I'm going to come round a number of people and ask for your thoughts, please, and if there's any outstanding issues that you want to raise. I'll start with the.
I think it looks okay with
the host CCGs, if I may. So I'll go first to Samantha, then to Jeff.
Thanks, Chair. No, I don't have any outstanding concerns. Being part of the clinical oversight group, I don't have any concerns in terms of the shortlisted options. My only remaining concern is the development of the out of hospital strategy, which needs to be linked in very sort of intricately with the new hospitals program. Otherwise, it won't work.
Absolutely, thank you, Samantha. Jeff?
Yeah, I think Samantha's sort of hit one of the major issues. The actual options, I think, are very eminently acceptable to the populations in Morecambe Bay, subject to how we devise the clinical flows and implement the clinical strategy and the like. But I think that's in hand. I think the major issue from the clinician's point of view would be the out of hospital model, and I know it's without scope of this programme, so that's not a criticism, but I think we need, and we've said it before, we need to be mindful of developing that narrative of how we will support the out of hospital programme, both primary care, community services and the like. So I think it's good. I think this is still a great opportunity for the people of Morecambe Bay and the rest of South Cumbria and Lancashire. You know, so I haven't got any major concerns. It's obviously, I think there's a personal sort of disappointment, and I know we can't do it, that we can't pull off a one big hospital project with the benefits of that, but there are very good reasons for that. So I'm happy, and I think the people of Morecambe Bay should be content, subject to those comments.
Thank you. And on the sort of host CCGs, Lindsay?
Thank you, David. I mean, yeah, I agree with my colleagues. I think the shortlisted options give us enough flexibility within those to look at that clinical delivery model really clearly and to think about how it's best achieved for the future in terms of the biggest efficiency across our services and thinking about how that fits in, as everyone has said, with the out of hospital transformation work as well. So yeah, I agree. I think clearly there's huge amount more work to do in terms of that really detailed understanding of each of those four options, as Jerry has said, and I'll be really keen to sort of see that more detailed work to help us in that sort of further decision making. But the four options that are being put forward, David, seem eminently sensible to me, and I think still give us enough flexibility within those, you know, to make the right decision for our populations.
Thanks, Lindsay. It's very helpful. Roy, what do you make of it all?
Okay, thanks, Chair. Yeah, I support the four options, and thank you, Jerry, for the work that you've done there. I'll just comment perhaps on the communication and engagement work that you've done, which from the paper is significant. I can see that the amount of communication you've done with, you know, patients, public and stakeholders, very significant. Just back to the options, Jerry, just a question. I think you'll have considered brownfield sites possibilities for new build, if that's to be the case, if it would dependent on which option is taken. And I think people now understand that building on greenfield sites is not perhaps the best way to move forward. So just to ask you if that was discussed at any time. Just reference back to the communication engagement exercises that you've been carried out. I'm particularly aware that members of the public sometimes can only attend at specific times of day due to work commitments and other commitments. And I think it's really important that we recognise that when we have these engagement exercises, that we take the opportunity to have those at different times of the day, perhaps sometimes at weekends, if that's possible. I think we need the broadest sense, we need the different discussions with different cohorts of the public, and I think to do that we need to expand that engagement exercise to ensure that we have the biggest possibility of engagement and discussion that we can. Thanks, Chair.
Thank you, Roy. Richard, thoughts, please.
Hi, David. Yeah. Thanks, Jerry. I felt some relief, I suppose, at the rationale about why certain options have been excluded, and certainly in my end of the patch, I think there was quite a lot of concern about one large central hospital and the socio-economic impact of that on our area. But the four that are proposed to go forward for further consideration seem very sensible, and I would agree with all of those. Be happy to endorse those. Echoing the thoughts of colleagues really about the clinical model, I wonder if there'll be a point in time where we need to share that, because it's as important as the new hospital programme itself, because within that it will help to describe how we might use these buildings in future and how it might help our communities develop further as time goes on. But I think my fear is that might be lost if we just think about new buildings and which sites. There's something about the opportunities that come and how we describe those to people. Yeah, happy to endorse.
Thank you, Richard. Peter?
Yeah, I mean, absolutely happy to endorse on behalf of West Lancs. I think it's really interesting for us because we're seeing this process occurring in parallel with the Shaping Care Together programme for our own local hospitals. I just want to reinforce and stress my agreement with the other chairs regarding the clinical model. I think there's a huge opportunity here. I mean, a once in a lifetime opportunity, and across such a broad area geography from north of Crosby right all the way up to Upper Cumbria, to have a number of hospitals that really meet an upside down clinical model, the one that we're used to, where the community has the larger chunk of the work, and the hospitals only do absolutely what is essential. They just want to sort of stress that this is, for all the wonderful work that's been done up to now, I think the real opportunities grow from here on in.
Thank you, Peter. And Kevin?
Yes, thanks, Chair. And firstly, can I thank and congratulate Jerry on getting to this point, because having been involved in the background, I've seen the amount of effort and work that's gone on to try and keep everything on track and push things forward. A contentious issue as ever, particularly when you start talking about engagement, both within the organisation and more importantly with patients. But I've been vastly impressed by how it's been handled. And whilst I don't normally single people out, I do feel I'd like to mention the work done by Rebecca Malin, Louise Barker and Alison Puente from Project Rome, and mainstreaming this new piece of work within the existing comms and engagement activity that Neil Greaves and his team have to cope with has been fantastic, and it's been a pleasure to work alongside them. So I do fully support the four shortlisted options. I think it's worth me mentioning that the least favourite option, or the least voted for option throughout, was the single hospital. So the four that we've arrived at don't come as any surprise, but I think it gives us that opportunity that others have mentioned. So that's it. Thanks, Chair. I fully support.
Thank you all. I've gone through all the CCGs now. I'll open up. David Blacklock, please.
Hi, thank you, Chair. I think, you know, what we see today is really encouraging. I think it gives us a really good opportunity to let the public know that we listened and we heard them, and I think we need to communicate that message really clearly. So, as Kevin's just said, you know, the least favourite option, the worry for the public, was the single site and all of the complications that brings for the public in terms of access. So I think this is a really great opportunity to say, look, we really clearly heard you. So let's not miss that. Secondly, I guess, you know, when we were talking to people across the patch, what was most important to people was the service configuration rather than the actual buildings. So almost we now embark on the most important part of the work, which is where will people actually get their services. So clearly engagement with local people will be hugely important. I wondered whether or not we've given, how much consideration we've given to what the next phase of engagement needs to look like. What scale are we talking? I guess I'm not looking for specific detail, but if we take account of what we've done so far, are we expecting to do more than we've done so far? Do we want to talk with more individuals? Do we want to improve upon what we've achieved so far? And I wonder if there's an opportunity for us to involve co-production more, to kind of really bring people more into the design of the engagement next steps. I think that would be quite an exciting thing to try. And clearly I'll lend the hand of Health Watch to the wheel really with all of this. So thank you.
Thank you, David. Really appreciate those things that you said. Neil, I'll come to you later to talk about this sort of further engagement communication piece. I've got Gemma there, please, then Debbie.
Thanks, David. It was just to reassure people a bit that we're working from a provider collaborative and the clinical integration group that sits underneath the provider collaborative with the new hospital programme very closely, and ensuring that as we look at developing the clinical strategy for Lancashire and South Cumbria, we sort of really think about all of those things that people have raised, and Peter Gregory and Lindsay Dickinson are on that clinical integration. So it's very much about how we start to think about, you know, where those services need to sit, as people have talked about, how we're going to engage the public, how we're going to think about working with out of hospital and place, as people have really, you know, very importantly referred to, because some of the pathways that we're going to be looking at first are very much end-to-end pathways. So we'll get the opportunity to start to work out how does it work within each of the places and the local nuances that we need in terms of health inequalities. So I just wanted to reaffirm really that, you know, we are trying to think of all of this as we build it and really develop it and start to sort of prioritise what it is that we need to look at first to support the development of the new hospital programme. It isn't about buildings, people are absolutely right. It's absolutely about how we deliver those services in the right place and as close to home as often as possible. Thanks, David.
Thanks, Gemma. Debbie, please.
Thanks, David. So completely support the work and the recommendations. There's a couple of things for me that I'd really welcome just exploring. So the first one is just a little bit more information around an assurance about how the process and the decision making is particularly thought about and considered the needs, the views, the impact on seldom heard groups and communities who are disadvantaged. So I'm thinking, you know, have we perhaps done an equalities impact assessment so far? How has that sort of shaped the decision making to this stage, with it being such an important consideration? And then building on David's point, there's been extensive engagement with the public so far that's clearly been effective, and a really strong voice that's playing in and impacting on decision making, which is fantastic. I'm just wondering if we've reflected on what's worked so far and sort of what the feedback's been. It's just interesting to sort of hear about the learning and how that will shape the next phase.
Thank you, Debbie. Jerry, can I just bring you back in straight away, because these are such important points?
Yeah, thank you, Chair. I'll start just around the comms and engagement, because there were a few comments around that. It's been an incredibly challenging but rewarding process around communications engagement, bearing in mind we started at the height of COVID, where we couldn't do any personal contact. We were totally reliant on electronic media. We've been able to now to support that now with much more one-to-one interaction. So it's been a very steep learning curve. I have to say there are some marvellous benefits of using digital technology, but you cannot also beat face-to-face engagement with people. So you can feel people's feelings and their understandings. We have worked with Health Watch and David very closely in terms of reaching out to a really broad range of seldom heard groups to gather their views and their thinking and what was important to them and not important to them. I can only stress that that becomes increasingly more important as we go through the next phase. As the comment was made, how hospitals of the future affect people's access to services, access to care, can only really be felt and discussed when you talk about the services themselves. So it's a really important part of the next phase. We've learned a lot. I have to say we've got a lot more to learn, particularly that balance between face-to-face contact and using digital technology. And we will continue to use things like surveys, which actually have worked very well. And particularly not just because David's there, but actually working with Health Watch and with the Consultation Institute has given a real balance in trying to be very personal, but also making sure that we are doing the right things at the right time. If I may just, David, just comment about the out of hospital and clinical part. I think it's really important to keep stressing that the new hospitals programme doesn't stand on its own. It is an enabler to much wider system transformation. A great future hospital delivering great care is depending on having great community services and great primary care. We're very keen to make sure we have the right size hospital, but you can only have the right size hospital delivering the right care if the whole system is working closely together and well together. So that is very, very much stitched into the programme, working very closely with the Provider Collaborative Board. But I would echo the comments around really now putting some momentum around our community and primary care work so that the value we present in right-sizing our hospital is not just a wish and a prayer and a hope. It's based on strong foundation of having a great system that works right the way across our care system, including our social care providers. Just to comment on Roy's comment around sites, we're at an early stage in terms of sites. We're very open and exploring all sites. No decisions have been made yet. The one thing I will emphasise is we are not only very conscious about site locations and their impact on access and equalities, but also maximising the potential to work with our partners, whether that's the local authorities, the town councils, or our universities, to really make this an enabler around our contribution towards wider socioeconomic benefit. So I think that's a really important consideration when we think about sites, as well as the use of the existing sites. Thank you, Chair.
Thanks, Jerry. I think it would be good for us to come back next time with a more detailed proposal around the next stages of engagement and communication that David and Debbie and other colleagues have raised. But just before I move on from that point, Neil, is there anything you want to add at this stage?
Just that the new hospitals programme has been positive, so I think those comments are really appreciated. We obviously have to produce a strategy for how we work with people and communities, and the new hospitals programme has been able to allow us to link in some of those discussions we've been having in place and locally about co-production, how we want to work with communities, to a programme, and actually been able to articulate that of how that works at a system level. So I think there's been lots of learning. I think we're absolutely embedding that in how we want this to work in the new kind of organisation that's been developed, and the partnership as well with Health Watch and other voluntary sector partners has been really crucial. So I know Roy mentioned before, but a big part of this engagement work was evening and weekend kind of sessions, going out and listening to different members of the public, and Health Watch were really helpful in providing some of that capacity and work, but also comms teams from each of the organisations as well. So I think a thanks to all of those people who helped to do some of that work was really vital, and Health Watch obviously work with volunteers to enable us to do that as well. So yeah, I think we can certainly have a wider discussion next time about some of those next steps around community engagement, co-production.
Thanks, Neil. And to Andy, I don't know if this was the point you were coming back on, Andy, but would welcome your thoughts on this, setting this programme in the context of the broader clinical strategy.
Thanks, Chair. That was why I was coming in. Gemma and Jerry have alluded to much of it already.
in that we already have an agreed clinical strategy within our ICS, and this is very much enabling us to implement or enable that strategy to come to life. One of the key areas was making sure that care is delivered as close as possible to people's homes. And so with this, exactly as people said, what we're doing in primary and community care is crucial. What we can't do is wait until this has come to an outcome before doing that work. But what we can also do is make that work have to fit in with our end model with this as well. So it's an iterative process that we're going through and trying to balance many different aspects at the same time. But if we just imagine if one of the recommendations had been for a single site, that would have changed what clinical model we were going to put in and what services were there. So we have to get a certain route down before we ask clinicians to do a lot of the work that is never ever going to be implemented. And it's that balance, and as Neil alluded to there, it's how we tell that story. Nothing is predetermined. Lots of people have said to me, oh, well, we all know this is going to happen. I think we have a robust process that shows that we're looking at the evidence each time and we are learning what the right way to do. That's why we've had a significant amount of money spent on this programme to make sure that the end result is the right result for the people of Lancashire and South Cumbria, not just one person's idea. So we have to be prepared for some changes. And further reassurance to Kevin, as Jerry alluded to, the clinical models has affected going from the long list to the short list with, for example, the radiotherapy centre. We've looked at the clinical models from a high level and made sure that what we're proposing will still enable us to deliver high quality, but not yet detailed clinical services. That's yet to come as we work up our short list of options. Chair.
Thank you, Andy. Very good. And the last word before I move on to Andrew.
Thank you, Chair. Well, firstly, again, thank you to Jerry and the whole of the team for getting the work to this stage. And I think the comments today have really endorsed the detailed approach that's been taken, both the public engagement and also the option development. Absolutely wanted to say I support the options, and it's obvious that they are still very distinct choices. It's clear from the work that Jerry's presented, there are material differences between each of them, and they will need to be weighed up carefully in the detailed work he's just set out. I'm really pleased that we've had the conversation about public involvement and engagement at depth. So when we come back to that, we'll be having a real sense of that while we work with the shortlist and probably preparing for a process of public consultation. So that's really good. And wanted also, Chair, to endorse the comments that people have been making about that wider primary and community services strategy. I think one of the legacy pieces of work for, let's say, the CCGs, but this existing system, is that the recognition that people have said that we need a complementary piece of work. I'm having various discussions with colleagues about how we might scope that. I think certainly by May, we should have something that we could be talking about around the scope of it, so that we know what we want to do as a whole system and how that might then work in our local areas. So I think there's a bit of an obligation on us to get to the scoping point now, so that the ICB, when it's created, creates enough resource for doing the work that mirrors the type of resourcing that's gone into the new hospitals programme. Not saying it's exactly the same, just that you can't do that work unless you resource it properly. So I think, again, we'll put that within the record that we need to come back to that issue too. Thanks very much, Chair.
Thanks, Andrew. Right, Jerry, we've got to, the approach taken has certainly been noted and explored in further detail in the discussion, and we as a committee endorse the short list of options. So well done.
Thank you, Chair.
An important stage for us to get to, and we look forward to at the next meeting you telling us more about the next steps. Right. Helen, CCG closed down, transition to the ICB.
Okay, thank you, Chair. You've got included in the papers the report, and I make no apology for a number of appendices that are referred to in the report, but that's just because of the stage that we're at the moment. If I can take you to page 22 of your pack, as we talk about the CCG close down plan. And you'll remember that when we had the delay to the legislation, we took a conscious decision at both the Transition Board and at this committee that we would continue to do as much of the due diligence that we could by the end of March, saving the fact that obviously for finance and HR colleagues, much of that work will continue into Q1. As a consequence of that, we shifted many of the milestones to the end of March. And one of the things that we put in place is an amended reporting system, which is attached to Appendix 1. The reason for doing this is I'm sure nobody would take assurance from me saying I'm the programme director, trust me. And we felt that we needed to have regular reports that provided assurance to our lay members on the transition board who provide that particular assurance process. So you've got at Appendix 1 that amended reporting process. And at Appendix 2 and 3, you've got the programme plan itself, and you've got the first pro formas that were submitted by the CCGs after each of their either weekly or bi-weekly meetings that are held to look at the programme development within each of the separate organisations. We've increased the number of executive working group meetings that we have to weekly, because some of the activity becomes more timely as we move forward with this process. And we've scheduled 2 slightly longer meetings, one next Monday and one on the 28th. The one next Monday, and Carl will talk a little bit about this when I hand over to him. The one on Monday is to really explore what's different from the 1st of April. So we're doing all of this due diligence work in order that we can do our first meter reading, as I describe it, and have completed some of the due diligence. But what we also want to ask ourselves is what's different from the 1st of April in terms of how we will function across the CCGs, and what are the milestones to the 1st of July, because reference was made before to the Mark Cuban letter, which clearly states that CCGs remain statutorily responsible in Q1, but we have to make sure that we're ready to shift that statutory responsibility come the 1st of July. So that meeting on Monday will explore that still further. We held on the 31st of January an engagement event, which was primarily aimed at our audit chairs, because what we've been trying to do through this CCG close down process is constantly seek assurance, because none of us wants to get to a point at some point in the future where there are questions asked about how we close down our statutory organisations. So as well as having our internal reporting processes, we've asked MIAA to provide assurance at each step of the way. And that engagement event enables to pull in audit chairs and other lay members into a discussion where we broke into 3 separate groups, focusing on the 3 important legs of the milking stool, if you like: quality, finance and people. So we were really able to explore those 3 areas in some detail, and at appendices 4 and 5 you've got the slides from that event. Carl will talk about sections 3 and 4 once I've finished, but just really to reiterate that whilst I focus on close down, it's clearly linked as the sender function in with the receiver function. You can't do the 2 separately. So there's a very close working relationship between sender and receiver. Carl attending the executive working groups that we have that focus primarily on close down, and then I also attend the weekly sender receiver ones, so that we're making sure that as we move house from the separate houses into the mansion, then we're actually really connected as we start to move that through that process. Section 5, which is on page 24, is where you've got a reference to the critical path. That's attached to Appendix 7. It's just to assure you that we have reviewed the critical path based on the new timetable for completion of the readiness to operate statement. So we've revised that based on the delay to the legislation. And the risk register is attached at Appendix 8. I would briefly like to refer to that, because in the report we talk about the fact that we were doing a full review of that at the executive working group that took place on Tuesday of this week. There were 6 risks on there that relate to close down, and actually in the majority of cases, having done that review, we will either be reducing the risk down to low or removing the risk altogether, and that's because of the work that's been done so far. So in relation to us not working together as a system and ensuring that the functions transfer correctly, we're going to reduce that risk. That's based on observations by MIAA in terms of the robustness of the process. There's a risk on there relates to not following the national guidance. Well, clearly that's exactly what we are doing, so we'll lower that one. And also in relation to the risk with regard to quality, again, we will reduce the risk around that because there's been a huge amount of work done by directors of nursing and quality leads to make sure that we already have a model for quality as we move forward. And we also have interim arrangements established with the ICS Quality Committee, and we're continuing to run our local quality committees and doing a specific piece of work in relation to quality in Q1, probably in June, which will ensure that from a quality governance point of view, that has been signed off by local quality committees before it is handed over to the new organisation. We will also take that opportunity to review provider quality accounts because that's an important part of the organisational memory as we hand over. The risk that I have to flag that does remain high relates to the risk around uncertainty with staffing. We have seen a number of staff leave CCGs, either going on secondment or taking opportunities to move into other jobs elsewhere. It's not surprising, is it? Because there isn't that certainty about what the roles and responsibilities will be for individual staff. And so there is a particular pressure on our staff in terms of conducting business as usual, managing the close down process, and then particularly for colleagues in areas like finance, the fact that we've got this 3 months extension to our lives as CCGs means there's that close down of accounts at the end of this year, opening of accounts for 1 quarter and then closing them again. So, you know, it does mean that there is an additional pressure on our staff, but we are putting mitigations in place to manage that wherever we can. And it's one of the reasons why we want to try and push ahead with as many functions as possible operating once on behalf of us all in Q1, so that that will ease some of the pressures on our staff. I'll end at that point and bring in Carl, because Carl, I think you wanted to just talk about sections 3 and 4 of the report.
Okay, thank you very much, Helen. And David, I'm afraid that I've got a problem with my camera, so I'm going to have to remain a faceless bureaucrat in sort of making this sort of presentation to you. Within the sort of paper that you've received, as Helen was sort of reflecting, whilst the due diligence process formally focuses on the sort of transition and transfer of staff data items to the new ICB on the 1st of July upon establishment, it's clear that there's sort of a real sort of willingness across CCGs to work to a system way of working where we can during Q1. And the paper talks about the areas that we've identified as being important in allowing that system-wide operating model to progress for the chosen functions. So one is around ensuring that we've got appropriate mechanisms in place for each functions that allow CCGs to exercise statutory requirements collectively during Q1, and ensuring that the associated reporting and monitoring within each of those functions again allows the statutory expectations of CCGs to be maintained. Now, Helen talked about the sort of workshop that we've got on Monday, which from a sort of sender and receiver point of view is bringing together and identifying those functions where we're already essentially working to a system operating model, and those where we can easily do so. And part of the consideration of that sort of meeting will be ensuring that we've got those sort of governance mechanisms and reporting functions in place that will allow us to give the assurance to NHS England that CCG statutory functions are being sort of maintained during those during Q1. There are some sort of technical sort of requirements that are going to be required to be in place during sort of Q1. Certainly a central storage location for handed over sort of information with protected access. It is important that we're putting those into place, but also looking to establish an MOU for data sharing, which will mean that for those people sort of working within, say, sort of shared sort of complaints teams or otherwise, can safely share the information which is held and owned by their organisations in delivering their sort of system operating model. So hopefully there's a bit more detail in the paper that you've had a chance to read about how we're looking to ensure that all of those requirements for those functions that we're going to sort of shift to a system operating model are in place by the 1st of April. The intention would be that for those functions that we're not immediately able to shift to a system operating function, that if we can do that during Q1 in May or June, then in the same way we will look to do that. The next section of the report relates to sort of policy alignment, which sort of takes us back to the timescales of ensuring that by the 1st of July that we've got, as best we can, alignment across the number of policies that are currently in place across CCGs. Now, you can imagine that there's a huge sort of swathe in terms of the what those policies relate to. They're sort of corporate policies, HR, finance, data, IT, and then importantly, clinical policies and medicines management sort of policies that are held by the CCGs. Now, there's a good piece of work which has brought together an understanding of all of those policies and where they are divergent and where they're aligned. And the paper sets out the sort of process that we would be looking to ensure that by the 1st of July, where we're able to and where it's important that we do so, that we bring those policies into line. So we're looking to where there's already alignment of policies, then we would look to sort of lift and shift those into the ICB, but ensure that during 22-23, there's a review of those to ensure that they're sort of fit for purpose. Where there isn't alignment, then we're looking to bring together a number of subject matter experts in each of those areas that we would look to sort of review those policies and look at, how many of those policies aren't aligned, how long it would take to reach alignment, what's the risk if they're not aligned, so that we can set out a prioritisation for alignment during sort of Q1, which would ensure that for those high priority sort of policies that we've achieved alignment by the establishment of the ICS on the 1st of July. So I think that was all I was wanting to say in terms of the that detail within the plan. But happy to take any questions.
Thanks, Carl. Helen, do you want to come back to you before I open up?
No, nothing further to add at the moment.
Okay, thank you. There's a huge amount in here. 8 appendices et al. Jeff, I'm looking if you're smiling or frowning.
Yeah, well, thank you, Chair. This is an enormous piece of work, and I did actually manage to go through all the appendices because I had a meeting cancelled this morning. So I'm just in awe of the volume of work, and but we're all human. And I couldn't for a minute say in my role on this committee, I know that we've covered everything. We haven't missed anything. Everything's there. And I trust you, Helen and Carl, but I absolutely, but you're both human. And we have Mersey Internal Audit come in to, I guess, proofread what we've done and check we've not missed anything. How do we know we've not missed anything is my question. How certain can we be that we've got 100% of everything covered? It's such an enormous thing. I'm in awe.
Do you want me to come back on each question?
No, I'll collect a few up, Helen, if that's okay.
Okay.
I've heard you referred to as many things, Carl, but human's a new one. I've got Andrew, then Debbie.
Thank you. Helen, once again, Helen and Carl, thank you for the work that sits behind all of this. And it is good actually that a committee like this begins to see the breadth and depth of something as important as this exercise. Helen's briefing was very nuanced. Used the analogy of moving house, I think, at one point. And I think one of the real challenges, and it will be a challenge in Q1, is that in a sense, we are clearing things up in boxes from the old architecture and we are moving to a new, but we'll move in and out of those empty rooms for another few weeks. And I think it's coming down function by function, actually, to a question of leadership and communication with staff, that we explain where we can begin to move into the new operating system and the new world. And we also remain diligent, as Helen has explained, on areas like finance and the accounts and whatever else she mentioned that still needs the closed down diligence. And I think that's a real challenge for some of our staff and also for leaders that are uncertain about their future. So this takes us back to the beginning of the meeting and the sense that as CCG leaders, we are obliged to work with the designate ICB, the leaders that are coming to join us, to make the success of this. Because actually we can describe it, we can build on the best work that we've done, and we're all in a single team approach. And that's the message I've been giving to our staff in the regular briefings that we've had since last summer. I worry sometimes when I hear some messages where people are getting irate or annoyed with each other because there's been some breaks in communication or there is some complexity that hasn't been resolved. It's inevitable in a process like this, I feel, and we have to reset ourselves. But again, a very nuanced but comprehensive briefing for which I'm really grateful, Helen. Thank you.
Debbie, please.
Thanks, Chair. No, it's fantastic work, and I was going to make a comment and then just an ask, really. So the comment was just to say that the MIA workshop that was held recently was fantastic. It was so helpful. So I know that the feedback from governing bodies at CCGs was really positive because it really enabled them to get closer to the work and sort of have that input and a deeper understanding. So thanks for organising that. The thing that's kind of troubling me, I've scanned through the appendices, and as Helen would expect, I've looked where there's red around risks, and I can see obviously that the risk around staffing has increased and it's red rated in the appendices. And I've had a quick look and I can see where it's being discussed, but I can't see and understand the mitigations that are in place, so I'm still quite worried about it. So I guess it's sort of an open question to Helen, that around that risk, where is it sitting in terms of mitigations? Are we clear what we're able to do and how we're hoping to stop it from getting worse or reduce it down? And is there anything you wanted to flag to us in SCC, given its remit, to sort of support around that?
Thanks, Debbie. Helen, back to you.
Okay, thanks. So first of all, Jeff, in relation to your point, how do we know we've not missed anything? We are sticking absolutely to the letter of the due diligence guidance that we've got, which is why our programme plan is very much based on that, so that we know that we're fulfilling the ask that we've got nationally as to what we're required to do. So that's one component. The value of having Mersey internal audit, I can't overemphasize, because it's a bit like, you know, with any lay members or non-executive directors, it's great to have somebody sat on your shoulder constantly checking and asking, have you, and that's the function that they provide. In addition to that, I have a meeting after each transition board with a gentleman by the name of Keith Bowman, who's doing some work across the Northwest, linking in with Jane Cass. So he takes me through it yet again around where we're up to and seeks evidence and assurance of what we're doing. MIA, in addition, are doing spot checks around when we've actually said we've done something, and we put it in evidence folders. They're doing spot checks where they're going into those evidence folders and actually looking to see whether we've actually done what we've said we've done. I don't actually know what more we can do. It feels robust, but I don't suppose you know till the end. But we are tested on many times, and not least of which the transition board, where I often feel like I need to go and lie down in a darkened room, don't I, Roy? Sticking with you with the moving house analogy and that which you talked about, Andrew, for me, the thing around our staffing is really openness and honesty, isn't it? And actually being really clear where we do and don't know the answers to the future for them. We talked about that this morning, didn't we, Neil, at the sender receiver meeting that we had, and part of our messaging might be, well, carry on regardless in Q1, because actually there's not a lot that is changing for a lot of individuals, but of course they're seeking that certainty of what they're going to be doing longer term, and we have to just try and keep to manage that as best we can, look after people's health, well-being and resilience. And that kind of leads into your question, Debbie. I think as I mean, I can only speak directly for the central Lancs CCGs in terms of all the work that we're doing to focus on people's health, well-being, staying very much in touch with our staff. And I'm pretty sure that my colleagues in other CCGs are doing exactly the same. I think it is about pushing wherever possible to do things once on behalf of us all, because that will relieve some of the pressures that we've currently got in some of our teams. And I think particularly for our finance colleagues, but also for our corporate functions, where they're working on close down, but they're also having to do all the business as usual year-end stuff. There is actually an updated risk register, Debbie, which would probably help with you, that mitigation stuff. I'm currently writing it all up because it was discussed at the exec forum on Tuesday morning. So there will be a slightly updated one, which will give you some better idea of the mitigations. But you'll see if you look at a lot of work that we're doing around health and well-being, constantly checking within our staff right across the system to see whether there's anything else that we can do. But there's going to be no substitute for giving people certainty about their futures, and I think that that's key.
Thank you. I'll come to Roy and then Paul Kingan. I'd welcome your view on this, please. Roy first.
Thanks, David. Yeah, I'd just like to, I think, formally record for the minutes that my thanks, personal thanks, and I hope that the committee members would agree with me, to colleagues, amount of work that they've carried out on behalf of all the CCGs in this process, because Jeff, you referred to the number of appendices, and well, we have to read them every time at the transition board, so you've only got to read that once here. So, but you know, the amount of work, the breadth and the depth of that work, I hope you would agree, is absolutely significant. And we did ask for, I think, Debbie, I think you mentioned it actually some meetings ago, that we have a report come to the CCGs on how the reform programme is going, and I think we found that that's been circulated. So thank you again for that, both to Helen and to Dawn, who's been working on that. So as I say, I would formally record my thanks, and there's the huge amount of work, as I say, that's gone on. It's really inspiring, I think, to know that we've got colleagues who work so hard within the CCGs and within our system, that actually has got us to the place where we are now. We know we're not finished yet, and there's work still to do, but there's a huge amount of pragmatism about how much work we can get done by the 31st of March. And I think we will continue to do that within the first quarter of the next financial year. Thanks, David.
Thanks, Roy. Very well said. Paul, where are we on your being assured scale at this stage?
Well, I'm fairly close to the work. I'm part of all the groups, David, in terms of the transition groups. We've got several groups across the patch. I know Helen's involved in most of those. And I think, you know, consistently every week we update on the project plan. We've had several workshops. I think I'm, you know, fairly assured. I think the big issue is staffing and how we get through 2 year ends effectively. The finance teams at the moment are really working hard. There's a lot of goodwill across the patch. Where we can work together collectively on things like planning, like some of the work that we're doing on efficiencies, we're having single leads for those programs, which is really good. So I think for me, it's the balancing act between how do we keep teams together and keeping the morale up at the same time as working through the prospective things that we need to do. And I think the other analogy I would bring in is, as well as the houses moving to the mansion, we've also got caravans in the places where we need to develop. We need to develop the architecture around the place. So, and there's a lot of goodwill around how we do that and involve the partners. But I think that's another whole set of frameworks and policies and procedures that we need to develop as we go. But obviously, first things first, I think we need to keep everything safe. Clinical services, all of the statutory duties, and I think there's a good effort to do that, and I'm fairly confident. As I say, it's really just making sure we keep morale up over the summer, particularly for teams who won't have much annual leave because of final accounts and things like that. So I would just like to say that the cooperation across directors and managers across Lancashire and South Cumbria is second to none. We all get on really well. The spirit of cooperation is brilliant to see within teams, and we've just got to try and keep going. And as I say, I'm fully assured with the plans, and we've reached out, to various organisations to help us, as well as the Northwest system as well. So I think we're doing as good as we can, David. So I'm reasonably assured.
Thank you. That's very helpful, Paul. Okay, everyone. That's good. Well done, Helen. Well done, Carl. Well done, other colleagues. And we note the update. We're all slightly daunted. I'll speak for myself. I'm slightly daunted, but the scale of the complexity of this. But it's very helpful for some discussions like this. And we'll need to stick close to you, or we'll stick close to this committee as we come over the next few months. Thank you very much. Right, delegation of NHS England's commissioning functions. Peter.
Thank you, David. And I will just put the slides on screen and I'll just walk through them at some pace, if that's okay. Just bear with me a second. So hopefully those are now in front of you. And again, apologies for the late circulation of these slides. I think what's really noticeable is that the pace around this has picked up over the last few weeks. We received some further guidance last Thursday, which is built into these slides, and we're also imminently expecting more guidance. I think we can expect that the pace around commissioning delegation to significantly pick up over the coming weeks. Colleagues will hopefully remember that there was a previous paper, which I was surprised when it was back in October, because it didn't seem that long ago, but in October 2021, where we talked about the options for the ICB in terms of commissioning delegation and some options around what was then a 1st of April 2022 deadline, which is clearly now July 2022, and some options around April 2023. What we'd agreed as an ICB is that we would look initially in a phased way to seek delegated responsibility for community pharmacy commissioning arrangement, recognising that we will automatically receive responsibility for primary medical services, that responsibility which is currently held by CCGs. We also then talked about some phasing around dental, optometry, specialised services and public health section 7A and agreed that we were very much looking towards April 2023 to take on some of those responsibilities, particularly in relation to specialised services and public health section 7A. Those also rightly involve some conversations with our other two ICB partners across the Northwest. Just looking at each of those different groups individually now, for primary care and for general practice, that means 201 contracts and £273 million worth of expenditure. Pharmacy 44 million pounds, and dental and optom, which, as I said, would follow in April 2023, as you can see on the slide. So significant financial values, and again a significant number of different provider partners with whom we will be commissioning services from. In terms of specialised services, we're still waiting formal national guidance around specialised services planning populations. The rather colourful box on the bottom right hand side of the screen is an early indication of what we expect those footprint sizes to look like. One of the things we received last Thursday was a confidential draft list of specialised services which we anticipate will be delegated to ICBs from April 2023. There are further conversations that need to take place with regional colleagues in terms of understanding the best fit of those commissioning arrangements, considering each of the ICB geographies, the different provider markets and landscapes, and the different capabilities of those providers. And again, that is work that I think is going to really pick up pace, as I said, over the next week/months. In terms of public health, section 7A, those relate to the services you can see in the indented bullet points there. So immunisation programmes, screening programmes, child health information, adults and children in secure and detained settings, and sexual assault services. We've had some early conversations with NHSEI colleagues who currently commission those services, and we've asked them as experts to develop a straw man for our consideration in June 2022, in essence what they think would be the best arrangements so we can review them and consider them. In terms of support for taking on these responsibilities, there were a number of different options that were presented to us nationally as part of the wider ICB HR framework around, at one end of the spectrum, staff aligning, and at the other end of the spectrum, staff transferring. The approach we're proposing for 22-23 is that the general practice and community pharmacy commissioning staff will align to the ICB. What we're then proposing is that from 1st of April 2023, all of those staff, so including dental and optometry as well, will formally transfer to the ICB. In terms of specialised commissioning and public health, section 7A, those arrangements clearly depend on the scope of what will and won't be delegated, which is still subject to discussion. And we, as it says on the slides, are remaining really open-minded to have conversations with our other two ICB partners in the Northwest to arrive at what is the best commissioning support model, which may potentially involve working with those other ICB partners. In terms of corporate support, I think positively from a risk management perspective, NHSEI will continue to provide corporate support for those commissioning activities into 2022-23 and beyond if we wish. So that's particularly finance, business intelligence, complaints, etc. One of the pieces of work we need to pick up in 2022-23 is to consider whether we want to continue with those arrangements or whether we think there is an opportunity and some benefits to be derived from integrating some of that service provision with our own ICB corporate functions, but very much a piece of work into next year, nothing that we have to do immediately. In terms of what that looks like in terms of staff, linked to the early conversation, particularly around NHSEI primary care commissioning staff, there are currently about circa 20 staff. Just as other members of staff are concerned to understand what their future looks like, those members of staff are equally concerned, and positively we continue to work with them on a day-to-day basis, and we continue to work on an integrated team basis, despite the fact that they have not yet formally aligned or transferred. And again, some of the activities on the chart on the right, which is one of the functional activity maps for the ICB. So this is around primary and community care, and looks at what activities will be undertaken where. At the bottom of that map, you'll see that much of the contracting, performance, quality and financial activities that the NHSEI team currently support, it is planned to continue to happen at a system level. So it is very much envisaged that those staff members will support those system activities. This next slide just confirms what I've previously said in that the initial approach is alignment of NHS-EI general practice and community pharmacy staff, then followed by transfer in April 2023. In terms of governance arrangements, I think it's absolutely recognising that this picture is evolving. Colleagues may recall in a number of different forums that just before and just after Christmas, we shared some initial thinking around primary and community care governance arrangements, which was supported. There's also a recognition, I think, picking up on Helen's previous item, that CCG primary care commissioning committees continue until the end of June 2022. In terms of future arrangements, I'd also signaled previously that they were like to change both in response to the emerging ICB and PBP governance arrangements, but also critically for this piece of work, the NHS-EI delegation requirements. We've now received about a week ago that draft delegation agreement, which has been considered by the ICB commissioning delegation group members. And as it mentions, I've not circulated it, but it is another lengthy document, and we are providing some feedback on that by this Friday to NHS-EI as requested. This next slide summarises what I think many colleagues have seen before, which was the draft primary community care governance arrangements. As I often say whenever I present this slide, it is subject to change, in essence, understanding what both the PBP and the final ICB governance arrangements look like. We are moving ahead with the left-hand side and the right-hand side of that diagram. So the single transformation programme and a shadow quality performance contracting and finance group. The middle bit of that diagram we are currently reviewing in light of both the delegation agreement and what we're aware of the evolving ICB governance thinking and decision-making matrix as well. In terms of the delegation agreement itself, it is interesting in a sense that it is a standard delegation agreement that will cover all primary care services. There is a separate agreement being produced around specialised services. There are a number of changes to the delegation agreement that CCG colleagues will currently recognise, in that there is a more formal shift of liability to the ICB. So colleagues may previously remember that the liability remained with NHS-EI, which also meant that there were stronger ties with NHS-EI in terms of their attendance at primary care commissioning committees and again reporting requirements. There are a number of new permissions, I'd probably call them, around onward delegation. And I think really positively, there is financial flexibility across all of those delegated budgets and wider budgets across the ICB. And not surprisingly, a duty that we'll have to comply with the relevant policy manuals. I won't go into all of this in a lot of detail, but the big, I think, pertinent point on this next slide is particularly around primary care commissioning committee requirements, in that there is now no requirement for us to have a primary care commissioning committee as they are currently formed, but there is an option to do so. And clearly, when the ICB is determining what its governance arrangements are, it will want to take a view in terms of where primary care commissioning decisions are made and the management of conflicts of interest accordingly. There is also some work that we have to do, just as the ICB does in a wider sense, in terms of establishment in going through a pre-delegation assessment process, and that we are on with, and that does form part of the wider ICB formation and assessment process. And our response to the assessment is largely providing our action plan and supporting information. As I mentioned earlier on, this project, and I'm not going to talk about cars, mansions or caravans, but this is a project that will continue well into 2023-24, and there's imminent guidance expected, which will require us to continually review our plans. As I said earlier on, I think it's going to become more intensive quite quickly. The updated project plan I will circulate to committee members and will be grateful for any comments. And again, I think the immediate focus is in making sure we've got a transition into the new governance arrangements. And finally, the ask or the recommendation to the committee is to receive this slide deck for information, provide any feedback, support the approach, but I think really importantly, use this as a vehicle to communicate to relevant committees and groups, including CCG primary care commissioning committees. Thank you.
Okay, thank you, Peter. There's a lot in the paper, but not all colleagues will have had the opportunity to consider it carefully, and some members of the committee will be more familiar with the issues you've raised than others. There's a lot for us to take in. I don't know if we can do full justice to the recommendations that you make beyond receiving the update for information, but let me open up and see what people have to say. Jeff, please.
Thank you, Chair. Thank you, Peter. As ever, a really lovely presentation when you do them. And I probably don't have major issue with everything you've got in there, but I can't be sure about that because I've only just seen it. Saw it this morning quickly, and now again. So when I'm going to start with the recommendations, then work back with some examples. So with the recommendations, yes, I can receive this. I'm going to give you some feedback now, but I think number 4 requires to be done. I want to share it with my colleagues in the CCG and in primary care and the like, because I don't know what they'll feel, and I think that's what you want really. So it's hard to say for your 3rd recommendation, we support this in a very definite and detailed way. Of course, we support it in outline, but I think we need to come back to it. So one or two questions and one example. So I have no idea what CHIS means, Child Health Information Service. It's probably like somebody in the office I walk past every day and I know intimately, but I don't recognise it. So you can answer that. Primary care commissioning. I think you sort of half said we're not sure where we're going there, but I think if we're going to one primary care commissioning committee, for instance, for the whole ICB, which I don't have a problem with in a way, I think we do lose the local intelligence. A lot of the stuff I go to the primary care commissioning committee in Morecambe Bay. I think if local people weren't there giving local feedback on the issues, I think that those nuances would be lost at a central committee, although I don't think I want 5 committees just for the hell of it. So I think we need to think carefully about that. And the other one that always worries me on your governance slide for primary care is that bubble around primary care networks. Now, I'm speaking about Morecambe Bay here because the other GPs here might have a completely different experience, but I don't think the GPs in Morecambe Bay think primary care networks represent them. I think that they recognise they're an important part, but practices often want to be represented in a different way, in a governance terms and in decision-making terms. So I think we need to recognise that's not a universally accepted model of feeding primary care feedback into the central governance of primary care. So that's just a quick snapshot. I could talk for hours, but I'll shut up because other people want to do. But very good, but I want to come back to it.
Paul Lancavitt.
Yeah, thank you. Thanks, Peter. A very clear presentation. I was just, it was a similar question to Jeff, really around the local intelligence and the soft intelligence that's been built up over the years in the primary care committees, and how do we retain some of that in the shadow period before they get disbanded. So, you know, obviously, I'm sure there's something built into the close down programme and the transition programme, but how do we capture some of those issues that each patch will understand its own primary care and where the issues are, and making sure that there's continuity with that. I'm sure you're aware of a lot of them anyway, Peter.
And Kevin?
Yeah, thanks, Chair. As ever, Jeff has covered some of the points I was going to raise, and they've been added to as well. It was primarily for Peter around the primary and community care governance slide that you showed. I don't know about colleagues. I couldn't actually read any of the things on the leaves. But it's around sort of how do we, if primary care is going to stay with CCGs till the end of June and then something else takes its place, there doesn't appear to be any handover type period where some of those quality things around previous relationships can be managed. And I'm just wondering, Peter, if you've given any thought to that, or as to whether you could perhaps start to integrate the existing committees with a new with the new system, somewhere that those really delicate relationships have been built up over many years are continued and not lost.
Peter, do you want to come back?
Yeah, thank you, David. The relationship bit, not surprisingly, is big in my and other people's thinking, and indeed, looking at who we're proposing to do what where and the governance that links to that, we actually would like to expand that. So when we take on community pharmacy, dental and optometry commissioning arrangements, the approach that CCGs have had in the relationships with general practice, we actually have a view that places should also build with those other three provider groups as well. So if anything, more of that, please, would be my response. The governance slide, absolutely recognise Jeff's point, and again we've had that feedback from other colleagues as well, and we do want to show that the PCN assembly, albeit is new, is an important place where PCNs come together, but we absolutely recognise that in places there are different representation and engagement models, whether that's federations, alliances or other. And one of the things we need to understand in more detail is in each place what those arrangements look like and how we build that into the architecture. So absolutely agree with that point. Jeff, in terms of CHIS, I have some information from Tricia Spedding which I'm going to forward to you, but I wouldn't do justice trying to explain it, so I will forward it from Tricia. In terms of Kevin's point around transitional governance, I again agree. I'm aware that there is thinking around ICB, integrated governance type committees. I also think in the interim, we need to develop what was the middle blue bob on that diagram as a bit of a holding space where we make sure we retain the knowledge and experience of our CCG primary care commissioning committees and start to transition into the 1st of July. And the plan was to do that over a 3-month shadow period from April. But again, there's a lot of work to make that happen. Absolutely acknowledge that.
Roy.
Thanks, David. Just a couple of quick questions, Peter. Thanks for the presentation. On slide 8, where you refer to Commission report support and corporate support, you've got a box there that talks about the primary care commissioning staff. I'm just wondering if that's the current state, the current whole time equivalence, or that's the expected workforce that we're looking at going into the future. Because your operating model on the right of that particular slide then talks about place, and there's a significant amount of work there to be done at place, as I know you recognise. So I think I just want to understand how those two would integrate, that the staff that's needed at place to provide that operating model, and the staff that you've indicated there on the left of the slide in commissioning staff. The second point I'd just like to refer to is about interdependencies, and I think clearly, I think you know, I think all colleagues will know on the call how we have interdependencies between primary care and urgent emergency care and intermediate care. So how will they be managed moving forward and into the future? Thanks, Peter.
Thanks, Roy. And the answer to the first question is that the slide has a very partial picture on it. So that's simply NHSEI, Lancashire and South Cumbria, primary care staff. There is a much wider group of staff that are mapped in excess of 150 across Lancashire and South Cumbria that currently work across primary and community care agendas. So that table's purely the Lancashire and South Cumbria NHSEI staff that would transfer.
Oh, right,
okay. The interdependency bit, again, absolutely acknowledge and agree with, and I think one of the things that it's helpful to see is not just the primary and community care function, but is all the other functions across the ICB, for which there is a bigger functional activities map. And again, I think you're right in that no one of those functions is an island, and we need to work across them. Equally, there is a big cross-cutting piece around population health as well. And I know those functional activity maps form part of the staff briefings that Andrew's doing over the coming weeks.
Okay, thanks, Peter.
Helen?
Thank you. It was just really picking up that point and expanding on a question. I think it was from you, Jeff, around that transition and how we don't lose anything as we move from local primary care commissioning committees into something broader across the system. And of course, that's an important part of the handover piece of work that we have to make sure that we do. And we have organisational memory templates that we're completing so that we capture you know, all of the issues that we've had going through our primary care commissioning committees locally over a period of time, because it's not just about sort of handing over current issues, it's about handing over those issues that we've dealt with in the recent past, because there continue to be lessons to be learned from them. So I think wherever possible, we're all trying to end up with closed business, but wherever there are still issues that you need to be aware of, that organisational memory is really important. So it will be part of that documentation, and it will be helpful if that could be taken to each of the local PCCs in their last meeting. Thank you.
Thank you. And Jane?
Thanks, David. Just to answer Jeff's question, the Child Health Information System, Jeff, it's the IT system that generates the appointments for babies and children to receive their childhood vaccinations and then collects the data afterwards for uptake coverage rates.
Thank you.
Okay, thank you, everybody. So, Peter, we need more discussion on this in the future. In terms of your recommendations, I think we can say we've received the update. You provided with some feedback for reasons that colleagues have said. The feedback raises both questions and gives support some of the direction. We because of the way we've handled the paper and the presentation, we can't take this as support for the approach outlined. There's nobody not supporting things, but we do need a broader and deeper discussion elsewhere. I do worry a bit myself, and I'm conscious that I might be more detached from this than many members of this committee. But there's 38 of us on this virtual meeting at the moment, and if I went to all 38 and said, tell me what you think that diagram on page 11 means, which are the critical arrows that go from one bit to another, we might not get 38 different answers, but we get a lot of different ones. So I do think that there's a process that you need to educate us and embed us more as a committee in some of the in some of the detail of deliberation. And I think when you come back next time, it would be helpful if we distinguish between the bit of this transition which is about having a safe audit trail on these hundreds of millions of pounds and good governance in terms of the money and the contract transition, and then unrelated to that, what opportunities this gives us to do things differently than we've done them before, and rather than it just be a transactional focus, and how we're going to set about doing that. It already looks to me as if we've lost 22, 23. You know, we shadow this, we try out that, and so on. It's very frustrating, but I understand why it happens. But I think if we distinguish between the keep us safe in a transition and good governance, but also then the opportunity that we'll have to do these things better before as we build our integrated care system. Right, thank you. Where am I now? Catherine and Roger, quality and performance report, please. If you can just highlight the items of most concern to bring to the attention of the committee, that would be helpful.
Will do. Thank you, Chair. So I'll take the paper as read, as you've said. March's quality and performance report covers a period which Omicron was impacting upon services, but despite the pressure, the system does continue to largely maintain performance standards. For urgent care against the A&E standard 4-hour performance, it was 73.5 in January, meaning a cumulative position of 77.8. The total number of attendances in January returned to pre-COVID levels following a previous dip. 12-hour waits continued to be high due to bed pressures, and at the end of January there were 446 people in hospital who tested positive for COVID, and there were still significant issues regarding staff absence due to COVID. With regards to cancer performance, referrals continued to be high, but pressures on workforce due to COVID are impacting on December's figures. Capacity and demand as well as pathway work is underway to improve the performance, particularly on skin. Mutual aid is being provided with across Lancashire and South Cumbria, and it should be noted that this will potentially impact on providers' individual performance as waiting times are evened out. The Quality and Performance Subcommittee reviewed in detail issues regarding aspects of quality in regards to cancer. Briefly on diagnostic performance in December, performance deteriorated slightly against a 6-week target, and the size of the waiting list decreased slightly, with only Blackpool Teaching Hospital showing an improved performance. The size of the endoscopy waiting list continues to increase, and providers are looking to the independent sector and insourcing solutions to increase capacity in the short term and capital solutions for the longer term. The non-endoscopy diagnostic waiting list reduced in December, mainly due to ELHT performance. The report is now including community diagnostic centre activity that's being delivered across the patch. Moving on to elective care performance, appointments in primary care remain above pre-COVID levels, with an increase in the number of held face-to-face. Whilst appointments are back to pre-COVID levels, referrals to the 4 main acute providers are not, which may indicate a future catch-up will be needed. Demand management activity with regards to advice and guidance continues, and with regards to activity, despite the massive pressures, recovery levels were maintained in the period. Elective admissions around 92% and outpatients just below 100% in December. A snapshot at the end of January shows a similar performance levels, which is a great achievement by our providers. The waiting list position at the end of December was a slight increase of 1,184, meaning the total waiting list for CCGs was 164,614, with 67.7% being seen within the 18 weeks target. Whilst the number of over 52-week waits reduced, the over 104-week remained stable at 854 at the end of December. There are some waiting list data issues that are being worked through, and those are noted in the report. 57% of the over 104-week waits are at LTH, who have a comprehensive plan to have 0 by the end of June. Just to point out that the waiting list figures quoted are for those services commissioned by the CCG, which include all providers, not just the 4. The 4 main acute waiting lists include non-CCG commissioned services. Appendix 2 shows the specialty with the greatest number of over 52 weeks remains oral surgery, which is not yet commissioned by the CCGs. We've also included a section on LD activity, as that is a local priority for the ICS, and I'll hand over to Catherine at this point. Thank you, Chair.
Catherine.
Thanks, Roger. Thank you, Chair. I'll start at item 7, the nosocomial disease. So as committee can see, there is an improved position in the number of outbreaks, with the highest reduction at BTH and UHMB. The number of nosocomial cases has also fallen significantly, which is positive to report at this point. The themes identified across our providers include that PPE adherence, hand washing, cluttered environments and poor ventilation. And the actions have been taken that audits are providing assurance that that has a positive outturn and a positive impact on that patient care. The report provides details on those individual hospitals and section 7.3, as committee will see. If we move to IPA and CHC, item 8, on the D2A, numbers continue to remain high, and they are continuing to remain higher than a pre-COVID position, We are looking to continue this and looking at new baselining figures, as those figures do not seem to be reducing. The same can be said as well in relation to fast track and fast track delivery. Incomplete referrals are reducing in number, which is positive, and this is attributed to new staff that were brought in and were funded through that work. So this is positive, and families are reporting improved outcomes for themselves in addition to those referrals being completed. The quality premium, 4 out of 5 of the CCGs did meet those targets in December 21 for completing that 80% eligibility and decisions within 28 days. So that is a positive. A trajectory has been set for achievement by the end of 21-22, but this isn't being met, and mitigating actions are being put in place to try and ensure that that is lifted. If we look at safeguarding in item 9, you can see there that the escalation areas are including staffing concerns and the level of work that is coming through in relation to serious case reviews, which was predicted at the start of the COVID pandemic. And we can see that in relation to the workforce and the pressures that are being put through across our populations. We can also see as well around that workforce and exploitation across our regulated care providers. So those are highlighted in sections 9.1, and we can see the emerging themes and trends in 9.2 and 9.3, which are highlighted. In relation to mental health, you can see from section 10 and 11, those pressure points in key areas around IAPT access, out of area placements and physical health checks, which relate to some of the performance outlined in the previous section. You can also see those ongoing pressures around CYP, children and young people across that. So all the narrative in the report looks at that recovery position, and we have tried to include, after a really helpful meeting with Debbie, to try and support that narrative and give some explanation into that. Item 12, in relation to LD and autism, the report outlines that current position for inpatient admissions and the discharges, along with the actions being taken to support that agenda and to support our patients through that pathway. The review of the investment priorities has taken place, and there's clear plans in place for those patients who are currently ready for discharge. We're working with both NHS England and NHSEI to ensure a smooth pathway for those people. Section 13 just outlines the complaints position, which includes complaints and PALs, and the statutory function that will transfer to the ICB as of the 1st of July, and the plans that are going into place to ensure that that can be stood up, and the work that will happen and continue to take place through this Q4 position into Q1. So I think we would ask committee to note the work that is happening around that. That does absolutely link to the close down work and is captured within that documentation. Thank you, Chair. Happy to take any questions.
Thank you. Again, a lot of things here. It reflects a system that's been under pressure for a long period of time. I think there's heroic work being done all over the different parts of our system to maintain access and outcomes in the best possible circumstances, but there remain some big challenges on this, a number of things in here where we simply have to find a way going forward of doing better than the performance in this report highlights. Just Roger, I don't mean to pick on you on like this, but just so that we're clear in this committee, when you say there is a plan to deal with the 104-week wait by June, are you telling us there's somebody else's plan, or are you telling us it's a plan which you have reviewed and kicked the tyres of and are satisfied it's the best plan that it can be?
I had a meeting yesterday with LTH and the Deputy Q, who provided me with that assurance. They are sending the detail over to me, I've not received it yet, but they are sending the detailed plan that they're working to. There's additional capacity that's being put on, and they are modelling it, and they're modelling it from the bottom up. So the approach that they're taking is very robust. I haven't seen the plan yet, but I am due to receive it. But I have had that verbal assurance.
Thank you, Samantha. Then Peter, please.
Thank you, David. Thanks, Roger and Catherine, for very detailed report and a lot of work going on. Just wondering, I've got two questions in relation to advice and guidance. The first question is the actual number in terms of advice and guidance increasing across the whole patch? And secondly, how much of that is not being converted into referrals? Do we have the data around those two?
Roger.
If I may, Chair, in table 6.1.19, there's a table there that highlights the change to the patient pathway. So usually, if what that shows is that if the appointment would have resulted usually in a referral to outpatients, 50% of those patients are being treated a slightly different way, so out of hospital. So that's really where that demand management kicks in. So it's there.
Peter.
Thank you. Two comments, if I may. The first is, and I know some of this has been fed back to Catherine and Roger, so I always feel a little bit guilty referencing. I always feel guilty commenting on such a detailed report as well. It's a fantastic piece of work, and there's a lot of detail, and it's only because there's a lot of detail that are we able to sort of be so picky about things. But there's an interesting placement of the primary care element in the elective care section of the report. One might misinterpret that and think the only role the primary care has is to feed into referrals into the secondary care, which of course it's not. But and I acknowledge that there's a wider challenge there, which we're going to tackle, which is how do you report on performance and quality in primary care. But so that's one point. But the second point is it's interesting that in that elective demand section of the paper, it talks about the target to return to pre-pandemic referral levels and trying to raise that because that's considered to be a good thing. And actually, if we were having a conversation about what we're trying to do with elective referrals pre-pandemic, we're probably saying we want a downward trajectory. So it's just being careful with that kind of supposition that that's a good thing. And actually, it relates back to what Samantha says about we really want to see those alternative pathways of care that take away activity away from the hospitals, which of course will then have a benefit on the waiting times as well. So just to make that comment, thanks.
Thank you, Peter. David.
Thank you, David. Yeah, just two kind of areas for inquiry, really. I suppose, obviously reading the report, you can see that we've got a lot of people waiting longer than we would want them to be waiting. So I'm really keen to understand what it is that we're doing to support them to understand where exactly they're at in the system. I'm just thinking, what might it feel like to be at the other end of a very long wait when you're in a great deal of pain or you're suffering from potentially a very worrying diagnosis? Again, I mean, this is, teaching people how to suck eggs, but what would it feel like if this was my mum that was waiting for a very important appointment or something that was causing her life to be really difficult? So keen to understand what we're doing to help people know exactly where they're at and how much longer they might wait. And my second comment is about the learning disability health checks. I guess I was reading that and feeling a bit disappointed that we're not doing better with those health checks. And whilst I know it's not massively different from elsewhere in the country, we know that people with learning disabilities are just, they live in a much shorter time, as your report highlights. And, really keen to just understand exactly how we're going to push that forward and really close that gap in life expectancy. It talks about a number of things in there. It talks about having some additional monies to help GP surgeries do more health checks, but I didn't end up feeling like convinced that we were doing absolutely as much as we possibly could, and wonder if there's more that we can do. On both of those points, happy to help, of course. So really, happy to work with colleagues to think about how we do better in those areas. Thank you.
Thanks, David. Debbie.
Thanks, David. I wanted to thank Catherine and Fleur for meeting me outside of the meeting. I'd raised a few queries and sort of asked for more assurance at the last meeting around section 10 and 11. I had a really helpful sort of discussion with them, and very thankful that they've taken on board a lot of the feedback to add sort of extra richness around those sections. You're going to smile at me, Catherine, because of course you add more richness and then I come back with another question, don't I, when you give more detail. And the thing that I just wanted to check in with you and see if you've got a view around, I noticed on sort of 11.5 you've given us for the first time around the eating disorder waiting times, as sort of an overview of how many referrals are coming in, how many are appropriate and how many are inappropriate. And you can really see more recently that a lot of them are really inappropriate. And I'm just wondering where those young people are going to and sort of how we're triaging and unpicking that, because it just strikes me where we've got a service under so much pressure and those waits are going up and up and up again. We've got patients who are waiting for a huge amount of time to find out it's not actually the right thing for them. So how are we sort of helping them, and where do they go and how else are they supported, really?
Okay, thank you. I'll come to Andrew for the last word, but Roger or Catherine, do you want to respond to the points that David and Debbie have made, please?
Just from my perspective, Chair, I think I welcome the comments that have been given. I think we can put some more narrative in the report next month around assurance on patient experience on long waiters, so I'll follow that up. Thank you, David. Generally, the last quarter of the financial year, there does seem to be an increase of the number of annual health checks that are done, but again, we are following that up, and yeah, there is more to do, and I don't think money in itself is the solution, the only solution to it, but we will follow that up. Thank you.
Can I just add to that, just briefly? I am conscious of time. With the long waiters, there are processes around the clinical teams contacting and having direct contact with nurse specialists in particular around that and around proposed coming in dates. So I can feed that through, David, in terms of what those clinical teams are trying to do to support those people who are waiting, and also those links with their primary care practitioners, which I'm sure lots of people on this call could comment on, because people will go back into those. In relation to the LD and the health checks, completely agree. There is lots of money going in and health accelerator schemes going in, because it isn't just about having one check annually, it's around those ongoing checks across the year and filtering people perhaps onto different pathways. So it may be a diabetic pathway, it may be heart disease, bowel screening, etc. So not just front loading that annual health check, but taking that across the year. Eating disorders, Debbie, I will get you further information around where patients are signposted to if that's not the appropriate way to go, but also how we're trying to capture those young people earlier so they're not waiting for a long period of time before being told they're on an inappropriate pathway.
Thank you. And Andrew?
Just an additional issue to report, and perhaps a proposal. The additional information, I think, relates to an ongoing process of inspection from the CQC in our system. They are looking at a range of different providers and specifically focusing on the urgent and emergency care system. They're also going to create an aggregate position for us working together as a system as part of their reporting process. They began that inspection process a few days ago, and they expect to continue it until the end of April. Just on a broad comment about the report, David, if I may. Obviously, Catherine and Roger have led the consolidation of this reporting process over the last 12 months, and we've had the Joint Performance and Quality Committee. I wonder now if we could ask that committee just to reflect on the way that we might want to use reports like this going forward as we move into an ICB. What does it mean from a so what point of view? Does it actually help to perhaps separate some of the quality elements from the performance, or does that become artificial? But just in terms of the management of it, and as you were implying in your question about elective care, there is a specific group in the system that is managing the elective care recovery process. What's the reporting between ICB colleagues, CCG and ICB colleagues, working with that and getting an assurance through a group like this? So I wonder over the next few weeks whether that Quality and Performance Committee would consider that issue, please.
It's a very helpful way forward, Andrew. Thank you. And thanks again to Roger and Catherine and others. Right, Brent, we've got your 2 papers for approval, items 10 and 11. Is there anything you wish to say by way of introduction?
Yeah, thank you, Chair. In relation to the outputs from the Lancashire and South Cumbria Medicines Management Group, there's 2 local positions which relate to inhalers for the treatment of COPD. In response to discussions at the last meeting, we've highlighted in the paper that there wasn't a public and patient engagement process around those, and the basis for that is because it's more inhalers into a population of already significant numbers of inhalers. The 2 inhalers are not expected to have any sort of detrimental financial impact. Lancashire and South Cumbria are really an alternative option. However, we are putting them in the place as a sort of second line to others because of their carbon footprint. So there's those 2 inhalers, and then there's 3 outputs from NICE in terms of technology appraisals that were considered by the group. So I'm just really happy to take any comments or queries and see if the committee are happy to approve the recommendations as set out in the paper.
Thanks, Brent. Very clear. Is anybody any concerns who wouldn't support the approval of these items? Okay, thank you, Brent. Approved. Well done.
Brilliant, thank you, Chair. And then the second paper relates to the outputs of the Commissioning Policy Development and Implementation Group. So there's 1 policy to be considered today, which is on Sacral Neuromodulation. There are a number of indications that these could be used for, around about 7. 2 of those are already commissioned by NHS England, so evidence was considered around the other indications. The policy was drafted and sent out for clinical engagement and public engagement, and there weren't any sort of amendments that were made following those 2 processes. The one sort of significant change that we made to the policy after initially writing it was in relation to an equalities risk assessment that was undertaken about the age criteria. So it's been made explicit that relates to patients of 19 years of age or older. So really just again whether the committee are happy to approve that policy as written.
Thank you. Brent, anybody wish to raise any concerns? We content. Well done, Brent.
Fantastic. Thank you, Chair.
Thank you. We've reports from the subcommittees, the Transition Board. We've talked a lot about that today, the Quality and Performance Subcommittee, the Collaborative Commissioning Advisory Group to receive and note. I've not been notified of any items of any other business. We scheduled to meet informally in this group on the 14th of April and then informal session again on the 12th of May. At one time we would have anticipated that the new architecture would come into place. We continue, as we've said earlier, to work now through Q1. I emphasise again how important this meeting is with its with the role it plays in ensuring we continue to progress issues for the benefit of our populations and patients and ensure a smooth transition as the statutory arrangements change at the end of Q1. And on that basis, I thank everybody for their attendance and contribution today. We've done good business and I look forward to seeing people on April the 14th. Thank you very much.
Thank you.
Thanks, everyone.